Brooks from Stanford University. My background is that I actually grew up in Minnesota. I went to college at the University of Chicago, Stanford Medical School, Johns Hopkins for general surgery internship and residency, urology residency, and then urologic oncology fellowship, and landed at Stanford in 1997. I can't believe it. So I've been at Stanford for a while. I am currently the Keith and Jan Hurlbut Professor of Urology, Chief of Urologic Oncology, and Associate Dean in the Medical School. We are going to focus today on more or less screening, early detection of prostate cancer, management of localized disease. So we're focusing more on the earlier phases of prostate cancer. I think in other programs, advanced prostate cancer will be or has been discussed more extensively. Prostate cancer is a very broad topic, so this morning we're going to be relatively focused on early stage disease. Now, what I wanted to do today, and what we all want to do today, is cover, like I said, kind of the aspects of early diagnosis of prostate cancer, both to give you a feel for I want to try and give you a feel for how to frame what's going on in prostate cancer right now, because it's an absolute mess. And then also look at some of the interesting things going on at our institution that are related to how we get our way out of this mess. Now, the mess I'm referring to, I'm sure you all know about, that prostate cancer has been in the press, and there's been confusing and contradictory things said in the press. So I want to try and enlighten that a little bit, but also suggest to you how from that confusion we can make some sense and think about how to manage patients a little differently, because the field is evolving quickly, and there are reasons for that. Now, one of the big reasons for that has to do with this right here, prostate-specific antigen. PSA was first isolated in about 1970. We know it's made by the prostate, and by the prostate exclusively. That's hence its name, prostate-specific antigen. Prostate-specific antigen can be elevated. All men who have a prostate have PSA you can measure in the bloodstream, and it can be elevated by any disease or any process in the prostate: infection, enlargement of the prostate, which 3 out of 4 of us get, prostate cancer. I don't know. Sometimes I have patients, I can't figure out why their PSA is elevated. It was FDA approved for management of prostate cancer way back in 1986. That did not necessarily entail screening. It was only approved for screening in 1994. That being said, PSA started to being used for screening fairly heavily in the late 1980s and really from 1990 on. And what that means is that when we screen with PSA, remember, only a fraction of men have prostate cancer. So that means that in this country we do about 1 million biopsies every year to diagnose 250,000 cases. So that's a lot of biopsies, and that's due to the fact that prostate cancer is not a very specific test for prostate cancer. So I would love to have a marker that's much better, that is, one that is more prostate cancer specific and not just prostate specific. Now, what has happened with PSA screening, before I go on to this slide, is that it has actually changed changed the face of prostate cancer in this country. It's changed what the disease looks like when patients walk in, and I'm going to give you a little display of that, because remember what's been going on in this country. We've been screening our patients, or screening our men in this country, over and over and over again. So as we cycle through our population of men in the United States and find cancers, it's changing what cancer looks like nowadays. So I'm going to touch on that just a little bit, and we can elaborate more in the question and answer session. Now, one of the other features that you need to be aware of with prostate cancer screening that underlies this whole cloudiness in what's going on in prostate cancer screening is the nature of prostate cancer. This slide's just illustrating the number of cases of prostate cancer, and that's what's shown over here, far exceeds the number of men who die of prostate cancer. You see a very similar situation with breast cancer. You see more cases, these are just different ethnic groups, than the number of women who die of breast cancer. And that's in opposition to things like lung cancer, whereas if you're found to have lung cancer, you have a very high probability of dying of lung cancer, okay? So prostate cancer has a lot that can be discovered, but only a fraction of men will die of that. We also know this from what are called autopsy studies, so men who die of all causes, so, you know, car accident, a heart attack, shot by a jealous lover, whatever it might be. And if you look at men, this was a study done up in Michigan, look at men who die of other causes and cut up their prostate in fine sections and look, you can find for men in their 30s, a quarter of them have what a pathologist would call prostate cancer. Men in their 40s, it's almost a third. Men in their 50s, it gets up close to 50% for men in their 50s and 60s. So there are a few cells in the prostate that a card-carrying pathologist would look at and say, this is cancer, this is prostate cancer. Now hold it a minute. Remember what I showed on those graphs, very few men die of prostate cancer. In fact, in this country, a Caucasian male has a 2.8% chance that when he reaches the finish line, that is, when he dies of prostate cancer, 2.8%. So if this many men have what we would call prostate cancer cells in their prostate, but only 2.8% of us die of it, that's an issue. Yes, question?
What's the number, bottom line?
That's just the number of patients that he did autopsies on.
So it's basically out of 11 patients, age 60 to 69, 60%, only 11?
It's only 11 in this study. As you might imagine, it's hard to do a study of detailed fine sectioning of the prostate. Similar studies have been done. In fact, these studies, some of these, this is the 1990s, studies dating back to the 1940s with thousands of patients have been done. And those numbers tend to hold up. So the risk of having a few cancer cells in the prostate almost correlates with your age. Okay. Now, remember what I told you about PSA. So think about this for a second. You have many men running around with a few cancer cells in their prostate. Some of them have cancers that are destined to be lethal, or not destined to, but are potentially lethal. So there's some men walking around with bad ones, and then others walking around with cancers that probably won't do them any harm. And then you start screening that population, and you start screening over and over again. So this little graph of these smiley faces, at the top here are men who have bad prostate cancer. I should use the pointer. These are men who don't have very bad prostate cancer. These are men without prostate cancer in the population. If you start screening, so screening round one, you're going to find a fair number of the guys with bad prostate cancer. You're going to dip into the population of men who have cancer that's never destined to hurt them. Screening round two, you dip a little deeper into the population of men who have cancer that's not destined to bother them. Find a few less men with bad cancer. Round three and round four. So you're finding proportionately fewer men with bad cancers, but they're there, right? And they're guys who will benefit from treatment, but you're dipping further into those autopsy prostate cancers. Okay, so what has happened as a product of that is that the US population is lower risk because of repeated screening over and over and over again. But that's not to say prostate cancer's gone away. It's just that the average guy found now, as opposed to before PSA screening started, has lower risk prostate cancer. We know this because we've actually looked at patients we've operated on. The size of the cancer has gone from about 5 cubic centimeters in 1985 down to about 2 cubic centimeters in 2000. So the size of the cancers has shifted. The grade of the cancers has shifted to lower grades. The US has lower grade cancer, okay? So now you do studies on patients who have lower grade and lower risk cancers. This was what was tabloid news, right? So the US, there were 2 studies that were done, one called the PLCO trial, in which they took men, they flipped a coin, 76,000 men, they flipped a coin, you get PSA testing or you don't. And they looked at 10 years later and asked the question, did PSA screening help? And the answer was no. It did not increase survival. They did a study that was reported in about 2011 in which they took veterans who had prostate cancer, and I can discuss the other faults of these studies there because there are real problems with these studies, but they took veterans who had prostate cancer, flipped a coin, heads you got surgery, tails you got nothing. and at 10 years it didn't improve their survival. Okay? Why was that? If you look at that veteran study of the randomized trial of men who had prostate cancer, 3/4 of the men in that study had low-risk prostate cancer. Okay? Those are men who probably would have never been bothered by their disease. Now, in parallel, there were the same studies done in Europe, mainly in Scandinavian countries, where they don't screen. Okay? One of the studies was called ERSPC, so that was the European research group working in prostate cancer, research study group working in prostate cancer. 160,000 men, huge study. They either got PSAs or they didn't. At 9 years, there was a relative reduction of 20% of death from prostate cancer if you got screened with PSA. That population was never screened. If you do PSA in a group of patients never screened, they benefit. Okay, so US is lower risk because of repeated screening. Europe, where they never screened, there was benefit. Same thing happened in a Scandinavian study in which they took men and randomized them to either get an operation or not. They saw a 5% benefit in survival, overall survival. 5% better chance you're on God's green earth if you had an operation versus if you didn't, if you had prostate cancer. That showed up at 8 years. It persists out to 15 years. Okay, so hence all of the confusion, right? The product of that we've seen in the newspapers, right? The product of that is the U.S. Preventive Services Task Force looked at the data just from the United States and said, okay, looks like screening and treatment don't help, let's stop screening. We give PSA a D rating, which means don't screen, okay? You know, in a low-risk population, okay, well, maybe that makes sense, but listen, you're throwing out the baby with the bathwater, because we know that if you find men who have high-grade prostate cancer and high-risk prostate cancer, they actually benefit. And in fact, in the veteran study, remember, most of the men were low risk. If you throw out the low-risk guys who were operated on and just look at the high-risk guys who were operated on, they had a survival benefit. That is, if they got an operation, they lived longer. Okay, if you look just at the high-risk people in the veterans trial. So what we're seeing now is that the screening has identified patients who have a low chance of benefiting from treatment, but others who have a real chance of benefiting. So as a product of that, we've learned a lot, or this is perhaps a lot of my impression, but many of us who are thinking a lot about prostate cancer screening, we've learned some things. We've learned that not all cancers are destined to hurt people, to progress and hurt people. So we're now recognizing we need to understand those cancers better. Those low-risk ones, we need to understand the high-risk cancers better at an early stage, which we need to pick out. I want to pick out the patients who are most going to benefit from treatment and treat them, and maybe not treat the patients who are not going to benefit from treatment. So that's the way the field is moving nowadays, in part a response to these clinical trials, and in part a response to the U.S. Preventive Services Task Force recommendations. What that means is I need to couple diagnosis with prognosis. What's prognosis? Prognosis is assessing whether the cancer is a bad one or not a bad one. Okay, so that's what we're working towards now. That's a big research focus at Stanford, but also a focus at many other institutions. What we also know is that as a result of this, we should be using active surveillance more in the men with low-risk prostate cancer. We should be watching more men. Now, let me talk about active surveillance for a minute. What is active surveillance? All these terms are thrown around. Watchful waiting was in the title. Watchful waiting has been used for years for what we do with men with low-risk prostate cancer. That's all shifted now a little bit, so I'm going to just give you a couple definitions. Nowadays, when researchers talk about, or clinicians talk about watchful waiting, that means a man's found to have prostate cancer and we're not going to do anything until the cancer spreads elsewhere, and then we'll treat him with hormonal therapy. That's nowadays what we call watchful waiting. I don't like watchful waiting. Most of us don't like watchful waiting. That's as opposed to active surveillance, which has more of a, I like the active term in it, right? So we're doing something. We're watching men closely with the notion that if something changes, so let's say I'm watching a man who has low risk, very small, low-grade prostate cancer. As I'm watching them, their PSA starts going up and I biopsy them and they have more cancer, or they have a higher grade cancer. I can intervene at that point. That is, I can operate on the patient or perform radiation therapy on the patient at that point. And that's exactly the guy I should be treating because he's in the higher risk category, right? So that's what the notion of active surveillance is all about. Now, this isn't a new notion, active surveillance. It's been around, but the reason we are now recognizing that we need to use it more often is because it's very clear that the treatments we use are not perfect. And the reason they're not perfect is because they have potentially life-altering side effects. This is a little bit of a confusing diagram, but I like it because it's kind of 3D-ish. And it just gives you an idea what's in the neighborhood of the prostate. So here's the prostate here. The bladder sits right above it. This is the rectum behind it. The man's kind of laying with his head down. So his head's down here, his feet are up this way. Bladder up here, urethra runs through the middle of the prostate and out through the penis. And these are the nerves that run right by the prostate that are responsible for erections, and erectile dysfunction is very common after treatments for localized prostate cancer of any type. The urethra runs through the middle of the prostate, so if you remove that prostate or treat it with radiation therapy, you can affect urinary function. In surgery, leakage, radiation therapy, potentially frequency and urgency afterwards. Also, radiation therapy can affect the rectum because the rectum sits right next to the prostate gland. So, because of these potential consequences and the fact that we're finding men who have prostate cancers that might not need to be treated, we have to think seriously before we pull the trigger and make the decision to treat a patient. And that's why active surveillance is gaining steam. And many of us, and many patients and many physicians are recognizing that a lot of patients should be managed that way. Who should be managed with active surveillance? I would say definitively men who have a life expectancy on average less than 10 years, right? Because there's a relatively low probability they're going to benefit from their treatment in terms of improved life expectancy. Men also who have low-grade disease. So this is kind of an or here, men who have low-grade disease. I have patients on active surveillance who are, believe it or not, in their 50s and even a couple in their 40s who I'm watching and waiting. But watching them expectantly, that is, doing biopsies periodically and so on. Some men with higher grade cancer can be watched with the proviso that if they're followed, they know that they're assuming some risk, and also that they're willing to show up and be followed. If they disappear, that's no good. That's a problem. Now, active surveillance, these are several studies that have been published of active surveillance. This is a busy slide. I just want you to focus right here on whether or not men are dying of prostate cancer, whether or not they're alive. 100% are alive in all of these studies, save one where a couple patients died after 10 years on active surveillance. So it looks like it's safe if you pick your patients right. They're not dying of prostate cancer. Now, if you look at patients who are placed on surveillance, there is so these are what are called Kaplan-Meier curves. This would be, if I draw a straight line, that's 100% of the patients. And with passage of time over years, and this is a scale of out to 14 years here, what we're looking at in the bottom one here, first of all, let's look at, are patients still alive with regard to prostate cancer? This is the Canadian trial in which they had patients with low and intermediate risk prostate cancer. Very few died of their prostate cancer, a few, so the curve isn't exactly at 100%. These are men who died of all causes, so heart disease, prostate cancer, and so on. So if you look proportionately, the men on surveillance, very few die of prostate cancer, more are prone to die of other causes if you place men on active surveillance. So that's kind of gives you a flair for the rationale for active surveillance. This is a long-term trial, again out to 12 years from Johns Hopkins. This is for men who are on surveillance. Are they still on surveillance, or did they get an operation or radiation therapy? That's what this curve is showing. And if you look, this is 100% of men on surveillance. After they're watched for 1 to 2 years, eventually some of them, something changes, their grade goes up or something, and they get treated, so the curve starts to go down, okay? So over time, some men get treated, but still plenty, half of them stay on surveillance, even at long-term out to 10 to 12 years. So it looks like active surveillance is safe, and it looks like it also means that a lot of men avoid those operations and radiation that potentially can cause harm. So that's where we are right now. And that's what's going on. Active surveillance is growing in terms of the number of men who are on it. It's gaining steam in the last few years. But we need to do a better job at sorting out the men who have aggressive cancer, because I'd like to know the minute they walk in the door, is this someone that's destined to need treatment or not? Because I would treat them earlier, right? So that's the next phase of what's going to happen, and there's a lot of research going on in this, picking out the guys who are destined to have that more aggressive disease and destined to fall off of active surveillance. So we need to come up with markers in the blood or the urine or even in the tissue to do so. Now, some of the research going on, this is some research from my laboratory. We've used things called DNA microarrays, which look at what genes are turned on and off within the cancers to come up with genes that are suggestive of aggressive versus non-aggressive disease. And so we've come up with a list of genes. We've been doing this type of work now for a decade. Some of the genes that we've come up with have been incorporated actually into some of the tests that are starting to come out that you might hear about on the market. Oncotype DX, for instance, includes a couple of our genes like AZGP1 and TPX2. Those are genes we discovered. But this Oncotype DX, let me just give you a little feel for this, because this has also been in the newspaper recently. What it does is it looks at biopsy tissue to try and predict which are the aggressive and non-aggressive versus what genes are turned on and off. First thing I want you to know is I have no intellectual property here. I'm not making a cent off this, okay? So just to be clear on that. Second thing is this is premature, okay? So this is released, it's out in the market, it's based on fairly scanty data. The studies that they've done have been very, very intriguing. They've never looked in an active surveillance population. They need to do that because they're using it to advise patients to go on or not go on active surveillance. They've never tested it in that context, so we have to be careful with some of these tests. There's a similar test from Myriad Genetics that has undergone similar scanty testing, even though the test is being marketed. It looks interesting. It, again, incorporates several genes we've discovered that are different from these genes, but we'll see. We'll see what's going on, what's going to happen with those tests. So this is all in rapid evolution right now. There's stuff out on the market that probably shouldn't be out on the market yet, but that might be the way that we get more data and learn about it. The other thing that we're doing is, as we come up with these markers, we need to be able to look at them in groups of patients and see if they actually help us. Now, the issue with that is, for these studies I mentioned to you about active surveillance, they've been relatively small in size in the past, and also we don't have samples or things to test from those patients. We don't have blood samples, urine samples, and so on. We recognized this was a problem 5 years ago, so we started what's called the Prostate Active Surveillance Study, us and about 10 other institutions. We now have enrolled just about 961. We're going to top out at about 1,000 patients. This is a month and a half ago. We're probably at 990 right now, so we're going to close that study out pretty soon. So these are men that we're following with low-risk prostate cancer. We're taking blood samples, urine samples, saving their biopsy samples. So now we have a platform on which we can look at these molecular tests like Oncotype DX, or some of the things we've discovered in our laboratory, or some of the blood biomarkers that are out there. So this PASS trial is one of the things that we've actually were some of the founders of, and also are through the Canary Foundation here, a local foundation, have funded, and now it's a huge resource that's a national resource that we're going to be using to look at these biomarkers. We also have funding through the National Cancer Institute to try and change the way we do diagnostics. So no longer do we want to measure just PSA in a blood sample. We're using technology from the School of Engineering that allows us to measure many proteins at once in the blood. It's a technology called the magneto-nanosensor. We're hampered to some extent by the quality of the available markers, the blood markers, protein markers, but the technology is working. We're actually checking patient samples now, but we're not using it in the clinic. We're nowhere near the clinic yet. We also have a second piece, which is to use a form of ultrasound called targeted microbubbles to try and localize cancers in the prostate. You're going to hear from Jeff Son in 2 minutes about other efforts in imaging the prostate. Right now, we diagnose prostate cancer by blind biopsy. It's the only cancer that's diagnosed by blind biopsy, and I think it's terrible because it doesn't allow us to understand what size the cancer is, where it might be located, and things that would give us important information that helps us treat patients. So we're working very hard at Stanford to develop imaging technologies that allow us to see the cancers. We're not there yet. There's some promising things Jeff's going to talk about. It's a thing in evolution right now. But what I envision is, and what we're working towards, is that patients walk in, we get a blood sample first and say, okay, this patient is at relatively higher risk for having prostate cancer above and beyond the PSA because we're measuring many things at once. We then do a targeted type of imaging in order to do our biopsy and do a better job at assessing men for their risk factors, and then make a decision. So what I'm envisioning is we go, this is the current paradigm, how we manage patients. If they have an elevated PSA, they get a blind biopsy, and then they go on to treatment. I think what we should be working towards and going towards is a multiplexed assay. We do an image-guided biopsy. We then figure out, is this a bad one, is this a tiger or a pussycat, and then go on to either do active surveillance or some type of tailored therapy that's best for the patient. So to summarize my points, prostate cancer screening and PSA are not dead. It's just that we have to be smarter about them. Many men still benefit from screening and treatment, but the treatments can have side effects. And because of that, we have to be very careful about recommending therapies to the patients if it's going to ruin their lives. So more men should be offered active surveillance. There are new tests coming down the pike, and you're going to see a lot of change in this field in the next 5 to 10 years because of those tests. And at this point, I'm going to sign off. What we want to do is have the speakers speak, and then we're going to have I see signals in the back there. And then we're going to have a question and answer session afterwards. So why don't we hold off questions now? And what I want you to do is, as you come up with questions, write them down. So write them on the pieces of paper in front of you, and we'll collect those and answer those here, just so people don't feel like they're disclosing their personal information if they're asking the question. Next up is Jeff Son. Jeff was just newly recruited to Stanford. Jeff did his college work at Georgetown, went to UCLA for medical center, and then we managed to capture him for residency training at Stanford. In a moment of delusion, he went back to UCLA for a while to do an oncology fellowship and also do some advanced work in imaging of prostate cancer and other urologic malignancies. We managed to talk sense into him and get him back here to Stanford University, which we're absolutely thrilled at because he's one of our stars. And he's going to talk to you a little bit about some of the work he's doing in diagnosis and imaging of the prostate.
Thank you, Dr. Brooks. I'm happy that you're all here, and I'm happy to be here to talk to you a little bit today. I'm going to echo a lot of the same themes that Dr. Brooks was just talking about, as well as expounding specifically in what we were mentioning in terms of prostate cancer imaging and targeted biopsy. So, as Dr. Brooks has mentioned, and we're all aware, there's been a tremendous amount of controversy related to prostate cancer diagnosis and treatment that's been covered in the popular press, looking at screening resulting in overdiagnosis and overtreatment, and surgery and radiation, which definitely cause side effects, but can have limited benefit in many patients. So this is the same figure that Dr. Brooks had in his talk, again from the study out of Detroit, for patients or people who were dying of traumatic injuries, gunshots, car accidents, where they look in the prostate just to find out how often do men actually have prostate cancer in their prostate that does not cause their death. And as he had mentioned, it correlates pretty well with your age. So a man in his 60s has a 60% or so chance, 80s, 80% or so chance of harboring prostate cancer that ultimately was not the cause of their death. So when you screen extensively for a disease that's that common in the population, you're going to find a tremendous number of cancers, and we do. Nearly 250,000 new cases per year. But also, as was mentioned, most prostate cancers are not deadly. And we see that in the difference between the number of diagnoses each year, nearly 250,000, and the number of deaths of prostate cancer, 30,000. If this was a uniformly deadly disease, we'd expect those two numbers to be the same. but they're not. At the same time, though, 30,000 is a lot of men to be dying every year. So I agree as well that we should not just ignore this and throw out screening and other types of early evaluation altogether. In the era of, we hear a lot about personalized medicine, where our goal is to make medical decisions that are tailored to the individual patient, what we really should be trying to do is identify specifically those serious cancers that have a potential to cause death. So how do we do this? Well, one benefit that we have is that in general, the more serious cancers tend to be larger. So the ideal would be that we would have some imaging test to find the larger cancers and specifically diagnose those. But unfortunately, until recently, it's been quite difficult to image prostate cancer. The standard of care for the last 20 or 30 years has been ultrasound, specifically a transrectal ultrasound. You see a sample image here. And what we find is that ultrasound, this is the prostate itself right here. This is the prostate. Ultrasound's pretty good at finding where the margins of the gland itself are. So this whiter stripe, this is outside the prostate. This right here is the prostate itself. But it works very poorly for trying to image inside the prostate. We don't see cancers well on ultrasound. However, because it's really the best thing that we have, we use ultrasound to help us diagnose cancer, and that's done with a transrectal probe. It's placed in the rectum. We use it to shine the ultrasound into the prostate gland itself, and then essentially randomly placed 12 different needles throughout the prostate and hope that we find cancer. But because we're not aiming at specific things seen on ultrasound, this suffers from two types of error. On one hand, we can overdiagnose or find very tiny, low-grade cancers that pose little risk to a man's survival. But on the other hand, we can miss, just by sampling error, larger, potentially more aggressive cancers that could be deadly. In fact, we see this quite commonly. So here's an example of a patient that we all have seen as urologists. This was a 57-year-old man who initially had a PSA of 6 in 2008. This is the graph of his PSA over time. We see he had 3 separate negative conventional biopsies as he watched his PSA rise from 6 to 18 over the course of about 3 years. So how do we prevent something like this from happening? Well, what I propose is moving away or adding to ultrasound prostate MRI. You can see here, well, this is the prostate on ultrasound. Here's a sample image of a prostate on MRI. And what we can do now is we can actually image many of these prostate cancers in the prostate itself. So here, this is what this part of the prostate is supposed to look like, this white area. Over here, this black thing is a prostate cancer as visible on MRI. This is called a T2 weighted image, but in addition to that, there are other parts of MRI that can be used to help visualize prostate cancer in the prostate. There's something called diffusion weighted imaging that looks, in this case, here's the abnormality in this prostate, that looks for areas that are very densely packed, as cancers tend to be with cells. There's contrast enhanced imaging, again, a lesion in the same spot. These are all images from the same patient. This makes use of the fact that prostate cancers tend to get more blood flow to them than surrounding normal areas of the prostate. And by combining these 3 different modalities into something that's called multiparametric MRI, it's been shown to greatly improve tumor detection. And specifically, it works best for cancers that are larger and higher grade, which are exactly the ones that we want to find. So now that we can actually see prostate cancers, many prostate cancers using MRI, how do we use that information to improve diagnosis? Because the MRI doesn't work well enough to get rid of the biopsy altogether. There are 2 different options. One is to do an MRI direct guided biopsy. And in this case, the man's laying on his front. This is kind of a cartoon, laying on his front in the MRI scanner. And they put a probe in through the rectum and directly put a needle into the tumor as seen on the MRI. Unfortunately, this is time consuming. These procedures can take more than an hour. It's expensive. Most hospitals are not able to offer this technology, and it doesn't provide the ability to do systematic biopsies, or essentially to look for cancers that were not visible on the MRI. A better solution, and the one I want to talk about today, is called MRI-Ultrasound Fusion. The basic idea of this is that a man will get an MRI a couple of weeks before his biopsy. The radiologist will look at it, and what he'll do is he'll essentially draw a circle around where the prostate is on multiple different sections. He'll also mark out where the lesions are in the MRI. And by doing that, we're able to reconstruct a three-dimensional version of the prostate, a three-dimensional model based on his MRI. Then at the time of his biopsy, using a fusion device, we do the same thing with ultrasound. Again, ultrasound works pretty well to find the contours of the gland itself. We develop a three-dimensional model of the prostate based on ultrasound, and then we fuse, or basically line up those models, so that during the biopsy, we can aim under ultrasound guidance at a lesion that's only visible on MRI. So this is an example. This is a man in his late 50s who had had a couple of negative conventional biopsies, and his PSA continued to increase. So he obtained an MRI that showed a lesion. This is his prostate right here. Here, this is an abnormal area. It's probably a little bit hard to see. This is the diffusion imaging. So we see a lesion on the left side of the prostate. We recommended that he get a targeted biopsy. This is at the time of his targeted biopsy. We can't see the lesion clearly on his ultrasound, but because of fusion, we're still able to aim at it nonetheless. These panels, D and E, which are projecting quite dark, are a three-dimensional kind of virtual model of the prostate that is also created in real time by this device at the time of the biopsy. The contours here are the gland itself. This blue thing is the lesion that was seen on the MRI. And all of these long tan cylinders are the biopsy cores as they pass through the prostate. And what we found in this case is a high-grade prostate cancer on the targeted biopsies. He then had a prostatectomy. This is a specimen from the prostatectomy after it's removed from the body. And we can see the cancer is present. Our pathologist lined this out for us on the left side of the prostate, corresponding to what was seen on the MRI and found on the targeted biopsy. So looking back at our data, this is looking back at about 500 or so patients we had performed targeted biopsy while I was a fellow at UCLA. And we had a couple of recent publications looking at this. This particular graph was a publication from last year. On this axis, we find the level of suspicion on MRI. Here is the proportion of men diagnosed with cancer. The green bars are all the cancers, and the red bars are the Gleason 7 or greater cancers, the ones that we care most about. And the general message of this figure is, as our level of suspicion increases on MRI, so too does our diagnosis of cancer. This is another figure from a separate publication. This is a very important one in my mind. When we're doing these targeted biopsies, we're obtaining some systematic biopsies, so just kind of randomly spaced in the prostate, and we're also doing targeted biopsies of the lesions that were seen on the MRI. And because of that, we can compare the results of the two. So what we see here, this is if we do systematic biopsy alone. We do find some significant cancers, but we also find a lot of insignificant, very small, low-grade cancers. On the other hand, if we're doing targeted biopsy, we actually find more of the significant cancers, but far fewer of these low-grade, low-volume, insignificant cancers that pose little to no risk to a man's life. So going back to that patient I mentioned earlier, the one who had 3 negative biopsies, his PSA kept going up. So when we saw him, he got an MRI that showed a lesion on the prostate that was on the T2 image, the diffusion image, the perfusion image. Our radiologist called this the highest level of suspicion on the MRI, and so he had a targeted biopsy. Here again is this virtual 3D model showing the prostate itself, all of the different biopsy cores. The tumor was located over here, and what we found on the systematic biopsies, no sign of cancer, but on the targeted biopsies, we found a Gleason 4 + 5 = 9, about the highest grade prostate cancer that you can find. He went on to get a robotic prostatectomy, and here's the pathology specimen afterwards, and you can see here our pathologist outlined where the cancer is located, and it corresponds exactly to what was seen on his MRI. He's done well, and now more than a year and a half after surgery, there's no evidence of any cancer recurrence. So the natural question then is, so if we can see some of these cancers on imaging, and we can target a needle into them, what about trying to treat the cancers as they lie in the prostate? And that concept, or what's called focal therapy, has come up, and there's a lot of interest. This is very early, but there's a lot of emerging interest in this. This has been termed the male lumpectomy. And the idea is to selectively treat the biologically aggressive prostate cancer as it lies in the prostate, hopefully with a treatment that offers reduced morbidity. So hopefully lower rates of erectile dysfunction, urinary incontinence, other side effects that could be associated with treating the whole prostate gland. This would be a minimally invasive procedure, one that somebody could go home, the man could go home on the same day, and potentially repeatable over time if new tumors grow up. Now, there has not been a lot of work done on this yet. This is one study that was recently published that was pretty well done, a small study, where they used high-intensity focused ultrasound. In this case, you can see an MRI a couple weeks after to ablate the side of the prostate where the cancer was located. 6 months later, that area kind of scarred down and involuted. And admittedly, these are a very small number of patients, only 20 people. But the 20 that had this treatment did very well. So almost everybody had strong erections afterwards, didn't have any sign of significant leakage, and only a couple of them had any sign of cancer at all on their follow-up biopsy at 1 year out. Again, this is very early, and there's going to need to be lots more study done before this becomes a recommended standard treatment. But in general, kind of take-home messages. Better prostate cancer diagnosis is long overdue. Our goal should be to diagnose those significant cancers that pose a threat to a man's life. MRI, when done well, greatly improves cancer imaging. Fusion enables targeted biopsies of lesions that we can only see on MRI. Targeted biopsy can preferentially detect those serious cancers, and focal therapy is coming, but clinical trials are needed to test its safety and efficacy. So again, to borrow a slide from Dr. Brooks's talk, our goal is to get rid of this kind of current paradigm where we have this one PSA test that's not specific for cancer necessarily, prompting a blind biopsy that doesn't really give us a great assessment of the risk of that cancer to a man's life, and then with only treatment options really available being surgery or radiation to the whole prostate. And instead, in the era of personalized medicine, moving on to better initial screening tests that, if abnormal, would prompt an image-targeted biopsy that would give us a better assessment of a man's risk to counsel him with more knowledge about whether he should be in active surveillance, focal therapy, or whole gland treatment with surgery or radiation. Thank you.
Next up is Mark Bujanowski. Mark actually went to college at Lafayette and went to the New Jersey Medical School before going to Columbia, where he got a master's degree in radiation physics. More power to him. And then went to Fox Chase Cancer Center in Philadelphia, which is really the premier place in the country, particularly for prostate cancer radiation therapy. Did his residency training there, was on faculty there since 2006, and we just managed to tantalize him to come out to Stanford. We're thrilled he's here. He's really going to be an important force in our prostate cancer radiation therapy group. Mark, before, I want to mention, if you have questions, pass them to the end of the aisle and we can start picking them up either during or at the end of Mark's talk. And then we'll be happy to answer questions afterwards. Mark, please.
Thank you, Dr. Brooks. Welcome this morning. I hope to wrap up the series of talks. Thank you for your attendance. It's great to have a full room. We're going to be talking about radiation therapy. Just a quick overview of where we're going. I want to describe to you how it is we talk about prostate cancer to put in perspective the elements of risk. That is, risks of spread, risks of disease recurrence with treatment. And I'm going to talk to you a little bit about external beam treatments and brachytherapy treatments or prostate implants. And then hopefully also give you a breakdown of what treatment options may be available to you from the radiation oncology department, both as a standard of care and exploring some clinical trials. The first thing we do when we learn that a patient has prostate cancer is to assess risk. And this is the risk stratification recommendations from the National Comprehensive Cancer Network, which is a collaborative group of institutions, cancer centers, that use PSA, prostate-specific antigen, Gleason score, and tumor stage to put patients into risk groups, low risk, intermediate risk, or high risk. And based on the risk, we make recommendations for treatment. Over the last 15 to 20 years, clinical trials in radiotherapy have demonstrated that higher doses are better. In general, increases in radiation dose of 8 to 10 gray have led to a reduction in recurrence on the order of 10%. So of key importance to radiation therapy for prostate cancer is dose. And the trick is getting the dose inside while minimizing side effects. And so there are various ways we do that. One way is something called volumetric arc-based radiotherapy. I'm going to discuss this with you. That can be delivered either in what's called conventional fractionation, which is a daily treatment every day, Monday through Friday, 5 days a week, no weekends, no holidays, for approximately 8 weeks. Or what's called more moderate hypofractionation schedules, typically delivered over periods of time of 4 or 5 weeks. There is brachytherapy, or treatment at a short distance. This is something you may have heard of, where we implant a radioactive seed, either permanently, that delivers the dose over an extended period of time, or temporarily, called high dose rate, which is a same-day outpatient procedure. There's also a treatment that has emerged called stereotactic body radiotherapy. This is the next step of moderate hypofractionation, to where treatments may be delivered from 8 weeks to 5 weeks to maybe 5 treatments in 1 or 2 weeks. A very active area of research. And lastly, androgen deprivation therapy. This is a treatment that hasn't been talked about too much this morning. The take-home message here is prostate cancer feeds on testosterone. We can shrink prostate cancer by depriving it of testosterone. We do that by tricking the body into making less testosterone with pills and injections. And so we often use this therapy in combination with radiation to help get an advantage, shrink the tumor, or maybe address 1 or 2 rogue cells that have escaped the prostate. So, I mentioned volumetric arc-based therapy, or VMAT. So there's a lot of catch terms in radiation oncology. There won't be a quiz on them today. But I want to demystify them, because like most things in American society and culture, they're often coined and used for marketing purposes. And I'm going to try to just demystify it a little bit for you. So basically, if you're a patient and you've elected to have radiation therapy for your prostate cancer, the first thing we need to do is mapping, right? You may have heard this from a colleague or from a friend. And so mapping is simply, you go to the department and you get a scan. Some departments have CAT scans, MRI scanners. At Stanford, we have 2 highly sophisticated PET-CT scanners. So what this does is create a map that helps me tell the computer where to point the radiation. And so this is just a picture showing the concentration of dose in and around the prostate here, buried within the bony pelvis, where bones are displayed in white And more red means higher dose, and blue means lower dose. And so you can see we have quite a good way to concentrate the dose right in the middle. And once we have this and we've verified it, we have many, many physicists within the Stanford radiation oncology department, and they're leading experts in their field. Linear accelerators, the Varian TrueBeam. So Varian is the company that makes this, was invented at Stanford by the Varian brothers. Okay. So there's a very strong tradition in physics, which is important for quality. And so this is one of the linear accelerators that delivers this volumetric arc-based therapy. And simply how it works is you lay on a table like an X-ray table, flat on your back, and this machine rotates around you, focusing radiation at the middle. You don't see it, you don't smell it, you don't get sick, you don't get nauseous, you don't lose your hair. You have no restrictions during treatment. And how the radiation comes out is much like how light comes out of a flashlight. So we point the flashlight at the prostate, but it's a very sophisticated flashlight nowadays. And this is just a picture of what it might look like coming out of the machine. And you see all of these fingers. This is called a multi-leaf collimator, and these fingers can move in and out as that machine rotates around. So treatment lasts about 2 to 3 minutes as it circles around the body. And what I want to show you here, that white is the beam. That's the flashlight. And you can see how it's changing in size as these fingers are moving in and out dynamically. And you can see how the intensity, the gray or white or black, is also changing. And so all of that is optimized in a computer setting to ensure we concentrate the dose in the prostate and we minimize exposure to the surrounding bladder and rectum. Those purple little circles there are fiducials. And so what they do is help us pinpoint the prostate, because ultimately that's the trick. So just before we begin, we either shoot an X-ray or do a very quick CAT scan to help see these fiducial markers so that we can fine-tune the positioning of the table to make sure the prostate's on the mark. Now, I alluded to the importance of dose, and clearly the easiest way to get radiation into something is to stick it in there. And that's brachytherapy, or seeding. And so this is a collective of results of all types of radiation treatments for prostate cancer, like external beam radiotherapy, so VMAT would fall under that. There is external beam radiotherapy in combination with implanting seeds, and there's seeds alone. And the take-home message of this slide is, for patients falling into that intermediate and high-risk categories that I talked about, patients treated with brachytherapy here in purple, or with combination, so the blue and purple ones, are at the top. Okay? So there may be inherent radiobiological advantages to implanting radiation in the prostate because very near the sources, the dose is exquisitely high. And so we're able to achieve very, very high doses, but for a very, very small area that helps us better spare the normal surrounding tissue. So how is that done? One way I alluded to is permanently. When the radiation is emitted over an extended period of time, a very common radioisotope used is iodine. It emits the treatment over about 2 months, expires after about 5 or 6 months. The seeds are made out of titanium, sealed, go in permanently, 90 to 100 seeds in the operating room over about a 2-hour procedure. And this is what the procedure looks like. Patient's positioned on their back with their legs up like a woman's legs in the gynecologist's office, ultrasound probe in the rectum. We visualize the prostate needles and seeds directly using ultrasound. We devise where the seed should go at the time. We don't go in with a recipe and, or a cookbook and try to reproduce it. We operate in real time. Here, this isn't displaying very well in the bright light, but you could get a sense of these strands of seeds that are anchored together in a bioabsorbable sleeve to help hold them in place while they deliver the radiation, typically positioned on the periphery of the prostate to avoid the urethra in the middle. And this is an example of what the isodose map looks like. So what's that? This is really the topography map that radiation oncologists learn to read that help us interpret how much radiation was delivered. And so this is typically performed in these permanent cases after 3 or 4 weeks where we confirm what the prostate received to make sure it was enough. Because after all, this is a procedure. And so many things can happen, and a lot of doing procedures is problem solving. So there's always what we call post-implant dosimetry. Well, if you consider low dose rate and high dose rate brachytherapy, there's a growing trend in that high dose rate brachytherapy, shown here in this solid line, seems to offer superior PSA control and survival compared to external beam alone or external beam and low dose rate seeds. And again, it comes out of what may be benefits in delivering the radiation over an extremely short period of time. So now, rather than 2 months, it's coming out over 5 to 10 minutes. And so what that does is overwhelm the body's response mechanism to repair any injury that may be occurring within the cancer cells, so we can flood it, so to speak. High dose rate brachytherapy is similarly done where we implant needles between the skin, through the skin between the scrotum and the anus, using a template, much like a battleship template. You can see the needles represented here. This is the topography map once again. High dose rate brachytherapy offers us the additional advantage of being able to optimize where the radiation is going. So rather than finding out where it went 3 or 4 weeks later, because one of the needles didn't go exactly where we wanted it to go, it doesn't matter where the needles are, because there are no seeds in these needles yet. They're hollow. We do a scan, we determine the positioning of the seed, and then we calculate how long the radioactive source should dwell within each position along each needle track. So the bottom line is we can get a much higher quality implant because we're afforded this luxury of optimization. The radioactive seed is delivered on a string that's housed within this machine. So there's a cesium source that's very small and very strong. And it comes out along a string. Each one of these cables is attached to these needles, and it goes in and out and in and out, each of these hollow needles dwelling for just a few seconds in each position every 2 millimeters, and then delivers the treatment 5 to 10 minutes, goes back into this unit. No more radiation in the room, no more radiation in the patient. You don't have to go home with seeds and worry about babysitting, reading to your grandchild, driving your daughter or daughter-in-law with the baby in the back any place, on vacation. It's a very clean procedure with very limited restrictions and is very easily incorporated into a daily regimen of external beam treatments. So last is this external beam technique I alluded to, stereotactic body radiotherapy. Another piece of equipment invented at Stanford. Now, I'm not just talking about the only machines invented at Stanford. The truth of the matter is the first linear accelerator and the first robotic linear accelerator were both invented at Stanford. So again, lots of expertise along these lines. This is the first CyberKnife. You can see it here. It has this robotic arm. That whole machine I showed you before is condensed into this little small head unit. This is what the radiation comes out of in a pencil-like beam. One pencil-like beam, no modulation, on or off like a laser. And you may recognize this robotic arm. It was featured in many Mercedes-Benz commercials of them doing spot welding. And so this is the same exact machine with sub-millimeter tolerances. And so while that arc therapy here has just one axis of rotation, this has an infinite amount of axes of rotation and is extremely good at mimicking what we can do with brachytherapy, implanting seeds into prostates. So let's say, for example, you've never had a surgery and you're not about to start now. This is a great alternative to getting that very high amount of radiation dose concentrated in the prostate. Just a word about hormone therapy. This is a collection of trials that have compared no hormone therapy or short-term hormone therapy to some or longer hormone therapy. And the take-home message is, every trial we've done so far combining radiation and hormone therapy for prostate cancer has shown that the combination is superior for intermediate and high-risk patients. And so they're very commonly an option for patients choosing to have treatment. They have downsides. The symptoms are similar to menopause that women experience, but are delivered for shorter periods of time and are intended to be temporary and not permanent. So sometimes they may be a feature of treatment. And I don't see a need to talk about it much more than that, other just to complete the landscape. So, what are the offerings at Stanford? This is a little picture I put together to show you, based on what category of risk you may fall in, that you have options. It's not a one-size-fits-all. It's not cookie cutter. There are things, there's the extended VMAT treatments that I described, which is very similar to this IMRT in this picture here. You can do that alone or in combination with the HDR brachytherapy, with or without hormones. You can do the external beam with hormones, with or without brachytherapy. There's all types of combinations that are based on a conversation that occurs between your needs, your goals, and what treatments we have to offer. We will also have a collection of clinical trials, collaborating with a few groups. One of them is the Radiation Therapy Oncology Group, which has defined radiotherapy for prostate cancer through its clinical trials over the last 20 years. And they have a number of trials that will be offered. One I want to briefly touch on here is in combination with hormones and this TAC-700 drug for patients with high-risk disease, where risks of recurrence may be 50% or more at 5 years. TAC-700 is very similar to that abiraterone you may have read about in the news. This is an advanced hormonal agent that achieves greater testosterone suppression that has been shown to be beneficial in more advanced patients. And so this is exploring, what if we take this drug that's helped men live longer when everything else has failed and give it to them up front? Maybe we'll be able to take someone who otherwise wasn't curable and cure them. Similarly, there's a trial through Antigen. This is a private company will be the only participants in the region exploring this drug called Prostate. So Prostate is an immunotherapy. So this addresses the often asked question of, well, can't we just help the body to do a better job? Doesn't the body eradicate cancers all the time and recognize them and sweep them up? Well, it does. But for some reason, prostate cancers can go under the radar. The goal of this trial is to give this drug that directly, with injections into the prostate, directly kills prostate cancer cells, stimulates an immune response, and bombarding the prostate with radiation showers the bloodstream with fragments of the cancer that hopefully the body can then detect and do its job of sweeping up in the event there's one or two rogue cells that have escaped. So again, a very innovative, forward-thinking trial that will be available. And last is this study we're going to do in collaboration with the University of Miami. My mentor and former chair is down in Miami now. And we've been working heavily with hypofractionation, which is that 8 weeks down to 5 weeks. And so this trial is going to answer the next best question, which is, should we do 5 weeks or should we do 5 days? And this will be available largely to the low-risk population and maybe some well-selected intermediate-risk patients on the lower end. Now, that looked very idealistic, and it is. And I just wanted to leave you with a little tidbit, which is, although there are 3 well-defined risk categories, risk is always thought about in a continuum. So there are no fine lines. There are people who, for example, in the intermediate risk category, who are closer to the lower end, maybe where risks of recurrence at 5 years is 5 to 10%, and then there are intermediate risk patients up at the higher end, maybe where the risks of recurrence border 40 and 50%. It's usually easy to identify people at the extremes, the really low, the really favorable cancers, and the really dangerous cancers. But there's always controversy everywhere in the middle, and that's just as true in prostate cancer as it is in anything else. And so what I just present to you is this one example. This is a very popular nomogram. If you Google prostate cancer, you can't avoid it. It's the Memorial Sloan Kettering Cancer Center nomogram that predicts who's going to live and who's going to die once you get prostate cancer. It's the law. So anyway, if you plug in these 2 patients, both 65, one with a tumor you can't feel on a digital rectal exam, one with a larger tumor that you can feel, both Gleason 7, but one 3+4 and one 4+3, one in just one of 12 cores and one in the majority of cores, with PSAs 5 versus 20. 2 intermediate risk patients, they both fall within the intermediate risk category. Look at your expected rates of control. Freedom from biochemical failure, freedom from recurrence of PSA, 83% for patient number 1, but only 50% for patient number 2. So, customization of treatment is probably indicated. And how do you do that? Well, you have to sit down. You need to discuss this with your oncologist. There are ways we do that. We assess tumor volume. We assess grade, the amount, the volume of high-grade disease. We assess the bulk of the tumor, again, like volume. And so I would just encourage you, if you are recently diagnosed with prostate cancer, if you're going through the process of figuring out what it is you think you want to do or need to do, always get a second opinion. Because I didn't show it here, but there's great data to show that quality of care goes up when you get a second opinion. And it doesn't have to come from 2 surgeons. It can be a radiation oncologist, a medical oncologist, a surgeon. It doesn't matter, because it all helps fill out the picture. And so thank you for your attention.
All right. What we will do is answer questions at this point. We've asked for comments written down, and we'll look at those. You can raise your hand also, so that's fine. I think we already have some questions here, and Jeff, I'll let you go.
So I have one here that's asking about insurance coverage for MRI of the prostate and coverage of multiparametric MRI. And yes, in most cases, insurance does cover MRI for prostate cancer, particularly for people who have previously been diagnosed or people who have had other imaging tests of the prostate already. But as we move along, there may be some for people who get an MRI before any diagnosis or before any other imaging that insurance companies may have an issue with that. But for the time being, it's true MRI is expensive. For the most part, the insurance will cover it.
I have a question here, which is, does Stanford do HDR brachytherapy? And the answer to that is yes. Yes, we do.
How about this second one? Yeah.
So this is a two-part question. And the first part of the question is directed towards the management of patients with large prostates. And so large prostates require special attention because larger prostates generally mean more difficulty emptying the bladder. Treatment with radiation in the short term causes inflammation. And so inflammation of the prostate makes the prostate even bigger, the problem with emptying even bigger, and in some cases patients can't pee at all, and we need to put in a catheter to help them through for a few weeks or a few months. And so the question is, how do you deal with it? Can you use drugs like finasteride, which is a testosterone-lowering drug, or other things? And so my typical management is I use an anti-androgen called Casodex for patients with big prostates, generally more than 100 cc's in volume. For patients who have prostates that are just big, not bigger than 100, size by itself is not necessarily an issue, and I don't always recommend patients shrink their prostate. But if it's symptomatic and we evaluate the extent to which the size is causing symptoms using a questionnaire called the AUA, or American Urologic Association Symptom Index Score, and if that score exceeds 20, then I advise patients to see a urologist, like Dr. Brooks or Dr. Son, to consider a treatment, a minor surgical procedure, not too different than a Roto-Rooter, to just see if we can improve the rate of flow before we begin, and that's usually all we need to do to address the problem. Now, brachytherapy in general for patients with prostates more than 60 cc's is not advised. In some experienced hands, we push that limit sometimes, especially if there's good urinary function irrespective of the volume. I would say implanting patients with prostates bigger than 100 cc's is rare. There are definitely reports of it in the literature, but these are by very experienced brachytherapists who've been practicing for decades. I haven't had much success in trying to shrink a prostate on the order of 100 cc's with hormone therapy like Casodex or otherwise with the hopes of making the prostate less than that 60 cc barrier. Many times I'm asked to see patients who've tried to do that. They've had hormone therapy now to shrink it, whether it's an injection or a pill. They have hot flashes. They may have difficulty sleeping. They've gained some weight as a result. And their prostate didn't shrink down enough, and now they're kind of stuck and considering external beam treatments. Anyway, so a little caution there before you start. Don't forget, hormone therapy is a treatment for prostate cancer. So before you start any treatment, just make sure you've done your due diligence and you've checked out all your options.
Okay, several questions related to PSA screening, and I'm just going to try and telescope some of them together. A couple questions about how long one should continue to do PSA screening. That's a huge area of controversy right now. Remember, PSA screening in itself has gotten a D rating for men of all ages. Current AUA guidelines just issued states that we should do PSA testing. So the AUA is our parent organization, mine and Jeff's. The American Urological Association. Current guidelines suggest start PSA screening at age 55 in a man who's otherwise has no other risk factors for prostate cancer, and stop at age 70. Those are the current guidelines. Those guidelines are based on that European screening trial in which they had men of a variety of ages there, but showed that there really wasn't a huge benefit in terms of increasing life expectancy. Remember, that's the bottom line, how long we're on God's green earth, in terms of increasing life expectancy if you're screening men over the age of 70. So now I feel a little queasy about that because I have several marathon runners who are 72, so I don't know if we should necessarily stop screening at that age. But I think that there's a fair consensus at this point that probably after the age of 75 we can slow down or stop screening. I have some other questions, so that's related to when to stop screening. Questions whether screening is dead. I don't think it is. Those are the screening guidelines now. I think we should continue to do it, and I think that there's good evidence, like I said, that screening will benefit patients. We just have to divorce screening from treatment. Okay, so if you screen a patient and maybe even diagnose a patient with a small amount of low-grade prostate cancer, that doesn't automatically lead to a therapy. That many of those patients can be managed by active surveillance. So I think that's the logical error that people make. So think of PSA testing the way you think about getting your cholesterol checked. Cholesterol is not the same as a heart attack, right? Cholesterol is not the same as open heart surgery. People are equating PSA testing with an operation and side effects or radiation and side effects. They're not the same. We can make rational choices all along the path to see whether there are patients that need to be treated or not. Let me pass it over to Jeff while I sort through a couple more questions.
All right, so I'll go through a few of these. There's one that asks about the number of cores in MRI ultrasound technology. So essentially we can do as many or as few as we want to. The goal eventually will get to the point where we're only doing the targeted cores, aiming just at the lesions that are seen on the MRI. Because at this point it's not clear that MRI finds every prostate cancer, and in fact it doesn't find all prostate cancers. And because the aiming is not perfect of these needles, we still do some systematic biopsies to pick up the ones that are missed by aiming or missed because they weren't seen on the MRI. Typically what I'll do is do 10 to 12 systematic cores and then some targeted cores, a couple of cores for each lesion that was seen on the MRI. There's a question about why taking 10 to 12 biopsies when the prostate is so small. So it's just a way to have a general consensus for what's considered a thorough biopsy. It's true. The sampling error is worse when you get to have a bigger prostate. But even then, even taking in a small gland 10 to 12 cores, we're talking about removing less than 0.5% of all the tissue in the prostate. So even with a small gland in 10 to 12 cores, there can be sampling error. Should I have PSA screening after the age of 70 if the PSA is less than 4? Dr. Brooks kind of just addressed that. I think in most cases the answer is probably no. Maybe in some cases it could be yes. Is it possible to remove only the cancer portion of the prostate? So at this point, the standard treatments don't remove only the cancerous portion, but yes, the goal is to get to that point where the imaging, the targeting, and everything is good enough that we could treat cancers within the prostate without having to remove or treat the entire prostate itself. And I have a few more. I'll come back to them in a minute.
Yeah, there's a couple questions about proton therapy, such as that used at Loma Linda. And so maybe I'll just take a minute or two and compare and contrast proton therapy to what I've discussed here. So external beam radiotherapy, whether it's using linear accelerators or cyber knives, relies upon photons to deposit the radiation dose inside the body. And this is where radiotherapy was born. So what that does is give us great confidence in that hundreds of thousands of patients have been treated with photons, and we know well what to expect from them. But also, excuse me, I just lost my train of thought there for a second. It must be my low blood sugar. It gives us a lot of confidence in what they do. But the problem with photons is that it deposits radiation dose on the way in. So what that means is the skin and tissues on the way to the prostate receive some radiation dose. And that's why you may have heard horror stories about, mom or dad or a great aunt who had some kind of treatment, whether it's breast cancer or something, and terrible burns. And so we don't see burns today because we've learned how to deliver photons in such a way to spare all those tissues on the way in. And the simplest way to think about it is to think about a ball field. And so if you go to see a football game or a baseball game at night, and there's those enormous spotlights up there. And if you look, it's very difficult to see the light as it's being emitted just a short distance from the light. I mean, the light itself is very bright, but in the sky, you can't really see the beam. But the ball field is lit up like mad. And that's because the ball field is at the intersection of all of these very bright lights. And so that's what we do with photons. We use multiple directions that intersect at the prostate to concentrate the dose, and the volumetric arc therapy is the pinnacle of that. It's just one big sweep, so it's like having an infinite number of beams all pointed at one spot. Protons are entirely different. Protons deposit the dose differently. They don't deposit any dose on the way in, they deposit it all in one spot, at one depth. And so the art is positioning the prostate at that depth. The technique they used is not this arc-based therapy or anything similar to a ball field. They just have two beams pointed at each other and try to position the prostate in the middle. It's a much older technique used 30 years ago. Comparing what you get in the end is not very different. There are some subtle differences, but you have very prominent chairmen like that at Harvard who come out publicly in peer-reviewed literature and said, look, you can't see a difference between these two on paper. Logistically, there are issues, but what you get is the same. We expect similar outcomes. Now, the experience with protons is growing, which is good. The challenges with protons that have already been addressed with photons is two. One, what if you don't hit the prostate? After all, the rectum is very nearby. It touches the prostate. That's how we're able to examine it during a digital rectal exam. And if you're off just by a fraction, we're talking millimeters, all of that energy that is being deposited so precisely with protons could be deposited in the wrong spot. And so what that may mean is unexpected rectal toxicity if the positioning is not good. We've learned over the last 10 years the prostate moves because of filling of the bladder and the filling of the rectum. We have mechanisms to get around that. With protons, what they do is they fix the prostate in one position by inserting a balloon in the rectum, fill it with fluid or air to pin the prostate against the pubic bone. So every day you go, you have a rectal balloon placed. Again, this is an antiquated technique, but adapted to this newer technology while the other technologies to address these improve. The reason we can't use the same technologies for protons that we use for photons is because the machine is completely different. The room is different, the logistics are different, and they just don't fit. They don't retrofit.
Okay, a couple other questions. Questions about what other diagnostic tools should be used in conjunction with or in addition to PSA. This is a rapidly evolving field. There are a couple things out on the market. As I mentioned, one of them, the Oncotype DX, but that's after the diagnosis of cancer. So maybe let's dial back. Man comes in, has an elevated PSA. The man wants to know, and the urologist wants to know, should we do a biopsy? There is a test out that's called PCA3. So this is a gene that has been found to be turned on a great deal in prostate cancer to high levels. Believe it or not, you can measure this gene in the urine. So there is a urinary test called PCA3 that is FDA approved now for men in a very discrete setting, and that is men who come in, they have an elevated PSA, they've had one biopsy that shows no cancer. And you want to know, should you do a second biopsy? Because their PSA is still elevated. So it's approved in that setting. That being said, through research that we're doing in the Early Detection Research Network, there's a paper coming out now that shows that even in men who've never had a biopsy, this test has some utility. Okay, so I've been using PCA3 in my own practice in helping make that decision, do we do a biopsy or not? There's ancillary tests to PSA. Believe it or not, there are different forms of PSA. So PSA normally floats around in the blood stuck to other proteins. Some PSA floats around all by itself. It's called free PSA. Free PSA goes down for reasons we don't understand very well, goes down in cancer. And it's high in enlargement of the prostate. So sometimes we measure a free PSA. There's even another molecular form that's just being released that's called pro-PSA. So this is a type of PSA that still is in proteins many times go through processing steps to get from the precursor form to the final form. This is a precursor of PSA. It's before it's been processed. It goes up in cancer because cancers don't process very well. So there's a test called Psi that uses that. There's tests coming down the pike. So there's another urinary test that's called the TMPRSS2-ERG fusion. So this is a particular gene change, an alteration where two genes get stuck together that happens only and uniquely in prostate cancer. And that can be found in the urine. The problem with the test, it only happens in 40% of prostate cancers. Okay, so probably if you have that, there's a higher risk you have cancer. If you don't have that, that is, if you're looking at the urine, if you don't have that, you still could have prostate cancer. It just could be that yours didn't have that particular gene mutation. But that is a test. We're evaluating it in the Early Detection Research Network. We've actually looked in our patients on active surveillance for several of these tests, and they can be somewhat helpful. So the final thing I'll mention is MRI. So MRI is and Jeff can talk more extensively about this. People are beginning to use MRI in the context of looking for cancers prior to biopsy to help guide biopsies. So that field is burgeoning quickly. It's early days in MRI, I would argue. So we don't know how it's going to really fit into that algorithm. Does every patient get an MRI? They're pretty expensive. So should we get an MRI on every single patient or not? So we have to figure out how to fit that in. We don't want to break the bank. So that's another imaging test that potentially could be used. It might have some utility even in active surveillance. So I'll stop there. Do we have more questions, Dan? Yeah, why don't you go answer that, and I'll get a couple others here.
So there's a question about the Gleason grading and what all these different numbers mean associated with prostate cancer risk. So Gleason grading is just a way to assess what the aggressiveness is of the prostate cancer. Gleason is a name of a pathologist that initially described this. And he looks at these cancers under a microscope and assesses how aggressive does this look. And there are a number of different patterns that they identify. It used to be there was a pattern 1, 2, 3, 4, and 5. Now we got rid of, for the most part, the 1s and the 2s, so there's just a 3, a 4, or a 5. Many times cancer can have multiple patterns in it. So instead of just getting one score for the cancer, we usually get 2 scores. The first number is what's most common. The second number is what's second most common. So if someone has, say, a 4+3 prostate cancer, it means the pathologist looks in the microscope and sees that there's some pattern 4 and some pattern 3. There's more 4 than 3, so it's 4 + 3 = 7. In general, the higher the Gleason score is, the more aggressive the cancer is. So the highest you can get is 5 + 5 = 10. The lowest you can be is 3 + 3 = 6. I have a good question about, can the results of an MRI sometimes say there is no need to do a biopsy and an ultrasound? So there's a lot of interest in this. At this point, the answer is probably no, based on available evidence. There's particular interest in using MRI in Europe for screening of prostate cancer, in part because an MRI in Europe, for whatever reason, is about 1/10 of the cost as it is in the United States. So there are studies that are ongoing in Europe where a man will have an elevated PSA, then get an MRI, and then go on to a thorough biopsy procedure. And the goal of this study is to look back and say, do those men with a normal MRI ever have significant cancers? Or can we eliminate the biopsy in some men with a normal MRI? It's too early to say that, but down the line, yes, I believe that we will have imaging tests that will be able to obviate biopsy in some men. A quick one about looking for subjects for targeted biopsy and subsequent focal therapy. So today, I don't have a fusion biopsy device at Stanford yet. I hope in the next 1 to 2 months to have one, and then we will start doing these. They are in a few centers, not very many in the US yet. One of the centers with the most experience was at UCLA. That's where I was during fellowship and had all of the exposure to this when we biopsied more than 500 men. So soon we'll be offering this. Focal therapy is probably a little bit further down the line, a couple of years down the line before we're doing much of that. And then how much time is in focal treatment and what are the side effects? Again, too early to say this. We don't know. There are a number of different energies that we may be using, whether it's high-intensity ultrasound or laser or cryotherapy. There are many unanswered questions. But that one study I pointed out, and there are a couple of well-done studies, very small numbers of patients, that looks quite promising, but way too early to give any definitive answer.
I have 2 other questions that I want to address. Then Mark is going to address one, and then I have one final question I want to wrap up with. The 2 questions I have, how to prevent prostate cancer? Are there nutritional things that can be done? This is a question I often get in clinic. It's a hard question to answer just because it's a hard thing to study, but I want you to think about it this way. There have been many studies done. These are called epidemiological studies in which you take a big, huge population of people and you give them a questionnaire and say, what are you eating? And then those patients are followed for a long time, and later on they look and see who got prostate cancer, and they look back in time and say, okay, what were they eating and who got prostate cancer? What are the things that have fallen out of those trials? Basically, anything good for your heart is probably good for your prostate. So think of it that way. Eat less red meat, eat less animal fats, eat more green vegetables, particularly some of the vegetables that have fallen out are in the cruciferae family, and that's broccoli, bok choy, cauliflower, Brussels sprouts. Remember George Bush didn't like broccoli when I used to give this talk. We've done research in broccoli, and I used to bring that up all the time. So eat more vegetables, eat less red meat. Think Mediterranean. Think also Asian diet. Those are the diets that have been associated with a lower risk of getting prostate cancer. in those type of dietary studies. Soy products, for instance, are found at fairly high levels in Asian diets associated with a lower risk of getting prostate cancer. So I think that's a reasonable thing. But the other thing is, I also have patients who come in with a diagnosis of prostate cancer and ask me to give them very detailed dietary recommendations. And the only caveat I want to give patients on that is diet is not like smoking and the risk of lung cancer, in which men and women who smoke have a 38-fold increased risk of lung cancer. People who eat meat have about a 2-fold increased risk of getting prostate cancer, or a 1.5-fold increased risk. So that risk is quite low. That being said, there are studies that suggest that eating well and exercising can help men who have prostate cancer. That is, people who do those things have a lower risk of dying of prostate cancer. So if you take good care of yourself, you probably are helping yourself survive longer. Okay, so I think those are reasonable things to do. I also want to give you one word of warning. Be careful with supplements. I'm not a huge fan of supplements. I have patients who come in with a long list of supplement pills that they take that really have never been tested in any kind of rigorous clinical trial, but maybe are tested on prostate cancer cells growing in plastic in the laboratory. It's a very artificial scenario, and the reason I give you this caveat has to do with a couple studies that have really stunned us. First trial was of lung cancer. So groups of men who were smokers at risk for lung cancer, 38,000 men, enrolled in a study to get either beta-carotene or a placebo. They chose beta-carotene because epidemiological study after study showed that men who had high levels of beta-carotene in their blood had a lower risk of getting lung cancer. They started this trial in Europe. It was called the ATBC trial. They broke the code early because what they found is people on beta-carotene had a higher risk of dying of lung cancer. And they thought, oh, maybe this is bad luck. There was a parallel trial running in this country called the CARROT trial. And remember, beta-carotene is from carrots. And so they broke the code early in that trial, same finding. High risk of getting lung cancer if you were on beta-carotene. A similar thing recently happened in prostate cancer. It's called the SELECT trial. The SELECT trial looked at selenium, vitamin E, the combination of the two, or a sugar pill, placebo. Again, about 35,000 men enrolled in this trial. I had a lot invested in this trial. We'd done research showing selenium protected against prostate cancer. I was a proponent of it. We got to the end of the trial, or close to the end, about 5 years out, no protections from selenium, big disappointment. By 8 years, I think, 7 or 8 years, the men on vitamin E slightly increased risk of getting prostate cancer compared to placebo. So I'm not a big pill fan. Eat good food. That's my advice, and exercise. Quickly, a couple questions about active surveillance. One very pointed question, which I think is a great one because it frames the debate. With active surveillance over 20 years, isn't there a risk of metastasis? Okay, that's what you want to know, right? And I have to be frank with you, we don't really know that very well. What we do know is this. Johns Hopkins has been running an active surveillance study since 1995. They're enrolling almost entirely men with low-risk prostate cancer. I sat with the guy who's running that trial at dinner the other night, a guy named Bal Carter, and asked him, Bal, how many deaths from prostate cancer in your study with 1,000 men from 1995 till now? The answer is 0. No deaths related to prostate cancer. I said, okay, what about spread to the bone? 0. We've seen no metastases in our trial also. In the Canadian study I mentioned, where they did see some patients who died of prostate cancer, they had 4 patients out of about 500 or something like that that died of prostate cancer. That was a study that enrolled low and intermediate risk prostate cancer. So men with Gleason 6 and Gleason 7, those deaths were largely confined to the men who had higher grade disease. But remember, it's 1%. 1% of the men on active surveillance died of prostate cancer. It's largely intermediate risk. So recognize there is some risk of death, especially with intermediate risk prostate cancer. That risk is exceedingly low. The last thing I'm going to leave you with is a study of Gleason grade 3+3. So this nowadays, remember, is the lowest risk prostate cancer. It's the lowest grade handed out these days. And this was done by a few pathologists at Johns Hopkins, University of Texas, and UCSF. That's, again, pertinent to metastasis. So what they did was they looked in their archives of all men who'd been operated on for prostate cancer, and they pulled out only the patients who had Gleason 3+3 cancer. And they asked the question, how many had spread outside the prostate to the lymph nodes? Because that's the first jump-off point for metastases. They had 14,000 patients. They found 22 that had spread to the lymph nodes. Pretty low. Okay, here's where it gets really interesting. The pathologist, being good pathologists, said, okay, I'm going to pull those 22 cases and look at all of them. They were all misgraded the first go-around. They all had higher grade cancer. So the answer was 0 out of 14,000 patients had spread to the lymph nodes. Okay, Gleason 3+3 cancer, if I could accurately know which patients have Gleason 3+3 cancer, I think it more or less behaves the way colon polyps behave. I think it's a very indolent disease. The problem we have, you learned in Jeff's talk, is sometimes we only hit the tip of the iceberg, and there could be some higher grade disease lurking somewhere nearby. Okay, so we need to have better imaging so we can biopsy better. We need to do a better job with maybe genetic tests of assessing risk. So that's what we're learning, and this is a learning process, but this is a product of the change in prostate cancer. Now I'm going to turn it to Mark, because he has another really, I think, pertinent question that many men want to know.
The question is, what do you do when the PSA comes back? So, not an uncommon problem. And the root of the issue is, while an elevated and rising PSA indicates that there's a cancer recurrence, it doesn't tell us where. And so often that's the dilemma that's not resolved until often many years have passed and we find that the prostate cancer has spread. So when patients are suspected of having a recurrence, we do scans to look for any obvious evidence of spread, like a CAT scan and a bone scan. If we find it, we use hormone therapy. Hormone therapy lowers the testosterone, starves out cancer anywhere in the body. That's a standard practice. For patients with no evidence of metastasis, a relatively low PSA, we may proceed to do a biopsy of the prostate. If the patient is interested in pursuing perhaps a second treatment, should that biopsy be positive. So again, it's just information gathering. So if there's evidence of cancer left behind that appears to be viable, then you could consider a second treatment. Second treatments on average are about 50-50. They can be associated with severe toxicity, urinary incontinence being one of them. Depending on what you read, risks of incontinence could be up to 50%. The treatments that I've offered patients in this scenario is seeding, if they've had external beam, which is the lion's share of patients. And the seeding that is done is akin to what Dr. Son discussed with focal therapy. So we try to do our homework. We look to see where was the tumor initially, where are the biopsies positive now. We do some mapping with MRIs to see if we can get a glimpse as to where the cancer may be. If it looks like it's just on one side, the cancer was only on one side, the biopsies are positive only on one side, I'll go ahead and just put seeds in that side of the prostate with the goal of minimizing exposure to any tissues that may not be the problem. And so brachytherapy is an option. On the other hand, you could consider things like freezing or cryosurgery. High-frequency ultrasound is an investigative procedure at this time, but is similar to freezing. It's just melting. And there you have it.
Yeah, the only thing I'll add to that is it's slightly different for patients, a patient who's had an operation, in that prostate's gone. Okay, so again, just to reiterate what Mark said, I like to think very simplistically, I'd like to put patients in two bins. Do they have a local recurrence? That is, are there cancer cells where the prostate used to be? or do they have a distant recurrence? Are there cells hiding elsewhere, bone or lymph node? So that's why we do the imaging test, mainly to look for distant disease. In the absence of signs of distant recurrence, I presume it's a local recurrence, and I send them over to Mark and ask them to radiate where the prostate used to be. Data from Stanford show that in that situation, if you give a little bit of hormonal therapy with the radiation therapy, we drop the PSA back to undetectable levels in 60% of the time. We published that paper a few years ago. So it's usually, like he said, about 50-50. About half the patients who have a recurrence after surgery benefit from radiation therapy by dropping their PSA. They tolerate the therapy reasonably well, actually. So the final question, I think, is a beaut. I think it's a wonderful question because it summarizes our morning nicely. And that is, there's much talk in the press that doctors don't give enough information to the results of treatment or screening, I'm going to add, for prostate cancer. That's been my experience. Please explain. Okay? Great question. I think from this morning you've gotten a hint why. Because I feel like we're only scratching the surface on how complex this issue is of prostate cancer, and we've been going at it now for, what, an hour and a half. The problem these days is you all come and see us and you have a 15-minute slot, right? So this is very complex, and increasingly in managing malignancies, prostate cancer in particular, but breast cancer is equally true. The research continues to build on itself, and as it builds on itself, there's more and more information we have to try and impart to our patients to help them, with us, make an informed decision. That's why we run into this problem. I just read an article this morning about, in the paper, is that there's going to be a shift even in private insurance to try and telescope patients into smaller visit slots. Okay? So imagine we're faced with this terrible problem of imparting this information so we can make decisions we're comfortable with into shorter clinical slots that we see our patients. That's the problem we face. That's the problem we face. That's why I think, you know, perhaps events like this, also the internet and things like that, allow us to pass on some information, but we might need to rethink the way we communicate information to patients when they come for a visit. And perhaps use some of the electronic media while you're waiting in the waiting room before you see us to impart some of this information. This is another area in rapid evolution right now. So healthcare in 10 years is not going to look like it looks now. And with that, I think it's time to sign off. Any other last comments? No.